Welcome to the Deep Dive. Today, we're tackling a specific condition using some revision notes. Riedel's thyroiditis.
Right.
Our goal is to really get to grips with the key info quickly. Think of it as a high-yield shortcut for your learning and recall.
Sounds good.
Okay, let's unpack this.
Absolutely. So Riedel's thyroiditis. Fundamentally, it's a rare type of chronic thyroid inflammation.
Chronic, okay.
Yeah, and the really distinctive thing is this progressive replacement of the normal thyroid tissue with dense fibrous tissue, scar tissue, basically.
So the thyroid gets harder.
Exactly.
Oh.
It leads to this characteristic hardening and enlargement, and importantly, this fibrosis, this scarring, it can actually spread beyond the thyroid itself.
Spreading outwards.
Yeah, potentially compressing structures nearby in the neck. It's also seen a bit more in middle-aged women and has this link, sometimes, with retroperitoneal fibrosis, another fibrotic condition.
Interesting connection. So we know what it is, but do we know what actually causes it? What kicks it off?
Well, that's the million-dollar question, really. The exact cause, still unknown.
Ah.
The notes mention possibilities like maybe an autoimmune link or some kind of inflammatory process driving it.
Yeah.
But nothing's been definitively proven.
Right. And risk factors, are there specific groups more likely to get it? Any, red flags?
Well, it can technically affect anyone, any age, any gender, but it does seem to show up more often in women, typically between, say, 30 and 50 years old.
Okay, women 30, 50.
But, and this is really key for revision, the notes are clear. There are no established associations with specific risk factors. We can't point to smoking or diet or anything like that.
Okay, so cause unknown, no specific risk factors identified. Got it. But what's happening on a microscopic level, the pathophysiology?
So the core process is that infiltration of the thyroid gland by this dense fibrous tissue we talked about.
Right, the scarring.
Exactly. And this fibrous tissue gradually replaces the functional thyroid tissue, the cells that actually make thyroid hormones.
Which could affect hormone levels, presumably?
It can, though often function tests are normal initially. And like we said, this fibrosis isn't always neatly contained. It can push outwards, extend into adjacent structures, and that's what leads to those really important compression symptoms you need to watch out for.
Compression symptoms, definitely key. Okay, so if you encounter a patient with a hard thyroid mass, what else should be on your radar? What are the main differentials?
Crucial point. You need to think about Hashimoto's thyroiditis, much more common, also autoimmune.
Mm-hmm.
Then there's anaplastic thyroid carcinoma. That's a rare but very aggressive cancer.
Okay, serious one.
Yes, and also something called invasive fibrous thyroiditis. So a useful mnemonic here might be HAI, Hashimoto's anaplastic, invasive, helps keep those differentials in mind.
HAI, I like that. Easy to recall. And how common is Riedel's, actually? Are we talking zebras here?
Pretty much. The epidemiology section is brief. It's a rare condition in the UK. Very rare.
Okay, so rare, but we need to know it.
Yeah.
How does it typically look in a patient? The clinical presentation.
The classic picture is often a painless, hard thyroid mass. And crucially, it feels fixed, like it's stuck to the surrounding tissues.
Hard, painless, fixed.
Exactly. Then you add the potential compression symptoms. So dysphagia, that's difficulty swallowing if the esophagus is getting squeezed.
Makes sense.
Hoarseness is another big one if the recurrent laryngeal nerve is compressed. And less commonly, but possible, are respiratory symptoms like shortness of breath if the trachea is involved.
Yeah, okay, so that hard mass plus potential swallowing, voice, or breathing issues.
Yeah.
How do we confirm it? What investigations are done?
Right. Investigations have a few goals. First, you'll want thyroid function tests, TFTs, just to see where the hormone levels are at.
The standard stuff.
Yep. Then imaging, things like ultrasound or maybe a CT scan, are really helpful to see the size of the gland, how extensive the process is, and if it's affecting those nearby structures.
Visualizing the problem.
Exactly. But the definitive diagnostic investigation, the one that really confirms it, is a biopsy.
The tissue sample.
Precisely. You need that tissue sample to look at under the microscope and actually see the characteristic extensive fibrosis. That clinches the diagnosis.
Biopsy is key. Okay, so once you have the diagnosis, how is RETAs managed? What's the approach?
Management is mainly focused on managing the symptoms, especially those compression symptoms, and trying to prevent complications.
Symptom control.
Yeah. Corticosteroids are often the first line. They can help reduce the inflammation and sometimes ease the compression.
Steroids, okay.
And in cases where the compression is really severe, causing major problems, or sometimes if the diagnosis isn't 100% clear even after initial tests, surgery might be needed.
Surgery for severe cases.
Got
it. And what about the long term? What's the prognosis usually like?
It's quite variable, actually. Some people find the condition sort of burns out or stabilizes, maybe even improves a bit.
Okay.
But for others, it can be progressive, leading eventually to permanent thyroid dysfunction, like hypothyroidism. And it's worth noting that it can sometimes recur even after treatment like surgery or steroids.
So variable outlook and recurrence is possible. What are the main complications we need to worry about?
It really circles back to that compression issue. That's the main driver of complications.
Right. Yeah.
So compression of the trachea, the esophagus, the recurrent laryngeal nerve, those are the big ones. This leads directly to potentially significant respiratory problems, swallowing difficulties, and persistent hoarseness.
The direct consequences of the squeezing.
Exactly. The notes also mention that permanent hypothyroidism, while possible, is actually relatively rare. So, of the little memory aid, think of the big 3 C's for complications: compression, breathing, swallowing complications, and the rare chance of hypothyroidism.
The 3 C's. Nice. Okay, so just to quickly summarize, Riedel's thyroiditis, it's rare, involves fibrous tissue replacing the thyroid, leading to that hard, fixed gland. Big potential for compression. Cause, unknown. Diagnosis, biopsy is key. Management focuses on symptoms, often using steroids, maybe surgery.
That's a good wrap-up.
Hopefully this deep dive has helped crystallize those key points from the notes for you. And here's something to ponder. Isn't it interesting how fibrosis, which is essentially the body's repair mechanism, its way of scarring, can sometimes go into overdrive and cause a whole different set of problems like this? Where else do we see the body's protective processes having unintended negative consequences?
That's a great point for reflection.
Definitely food for thought. Now, if you want more detailed revision resources or want to test yourself with practice questions, do head over to passthemsra.com.
And don't forget, for loads more free learning materials, you can also check out freemsra.com.